Thank you very much, Robert. It's a pleasure to be amongst you and to talk to you about the second type of study that Bianca talked about today. So she talked about the observational study where you try to get as many people as you can who have MS and as many people as you can who do not have MS, and then try to look at the abnormalities that you may identify by Doppler as sort of suggested by Paolo Zamboni. The second type of study that can potentially help you in establishing an association or causality is if you have an abnormality and you reverse it, the disease should go away or at least get better. And so that is the rationale for, or I should say, that is the premise for the premise trial. This is prospective, meaning these patients have had MS but have not had any procedure done, and then would be looked as to how they respond in the future. Randomized, meaning we have two groups of patients, one that will be treated and the other one that will not be treated. Both will be followed in the future. Endovascular therapy. This is sort of a general term. Endo means inside, vascular meaning blood vessels. So this is therapy being performed from inside the blood vessels. In this case, opening up blood vessels by using veins and using balloons to open those veins in multiple sclerosis. And so that is the premise trial. The opportunity that this provides us, which is not really easily doable in the cross-sectional component, is that you can investigate a much smaller number of patients in a much more intensive fashion. So one of the issues that has clearly surfaced is the great enthusiasm for this hypothesis. The enthusiasm stems from the relative simplicity of the idea that there is a reduction in blood flow drainage resulting in iron leakage, resulting in inflammation, resulting in MS. But the problem here is that when you look at all the individual factors, especially in larger cohorts, and you try to use as a screening tool a Doppler, and try to use the criteria established by Paolo, we find that things don't match up as well. And so it is with that consideration that when we were designing this trial, we thought we would look extremely extensively at every conceivable possible modality that we have available to us to study these patients and their veins. And so we are looking at a whole bunch of different diagnostic tools, and I'll list them in short order, to study these patients. The second component of this is the therapy, the liberation treatment, as is popularly called. It's a very nice name, and we would like for it to be actually very true, but the fact of the matter is that because most of these procedures are not being done within the constraints of a properly conducted trial, their results remain largely folklore or internet discussion or chat room panels, rather than being published so that they could benefit the larger cohort of population, such as the one that is in this room and throughout this planet. So for those who have a few means, they can potentially get the therapy, but the larger cohort don't know how safe is it, what are the risks associated with the procedure, what are the short-term benefits and long-term harmful effects of conducting the trial or conducting the procedure. So that was the goal of our trial, to really look at this very, very, very carefully and see, well, how should we do this? Because That's the third element. What constitutes a blocked vein, and what constitutes treatment for that blocked vein? Is it balloon angioplasty? Is it stenting? Is it this kind of balloon or that kind of balloon? What is narrowing? What is not? What is normal? What is not? These are all unanswered questions. And so they really need to be studied in a very sort of methodical fashion so we can really come up and say, well, this is what we did. We did step 1 to step 10, and these were our results, so that other people could potentially do the same thing and then duplicate or improve upon or sort of change the results to say, well, if you had changed step 2 to this, you'll get a better result. So that was the second goal of our trial, to really try to list exactly what we did and exactly how we did it. This trial, like every other trial being conducted at the University of Buffalo, is being conducted only through the approval of the Institutional Research Review Board. And this body consists of community members and scientists and clinicians who really look at every study protocol to make sure it is scientifically valid, and it's humane, and it's ethical. And we did pass this without any significant modifications to our proposal. Second, although MS has been largely a purview of neurologists and neuroscientists, intervention is primarily a purview of radiologists, vascular surgeons, and neurosurgeons like myself. And so before we can come together to design a trial, we really have to develop a collaborative effort. And the University of Buffalo is an incredibly unique place where we happen to have one of the most renowned centers for MS research in the form of the Jacobs Neurologic Institute, the Baird MS Institute, and BNAC, as well as one of the most renowned places for endovascular treatment of blood vessel disorders that affect the brain and neck, which is the University of Buffalo Neurosurgery. And so this was really a marriage made in Buffalo, which was perfect for conducting this kind of study. And so these were really remarkable collaborations that we were able to put together. The last part of this slide is, the fact of the matter is that we are all humbled when our aspirations are not matched by our funds. That's the reality we all live with, and that's true for research as well. And so we are extremely grateful that Kaleida Health, based on the incredible enthusiasm of the investigators, decided to bankroll the entire trial so that the trial would not cost anything to any of the patients. No diagnostic fees, no interventional fees, no hospital fees, all would be covered, because the moment you start putting money into the mix, it really starts becoming difficult to clearly state if judgment was completely unbiased and not affected by monetary concerns, both on the part of patients, because not everybody can afford something, and as part of physicians as well, because financial considerations come into play, because these are a reality of our existence. We are also incredibly grateful to a variety of industrial sponsors who paid small amounts of money, including Volcano Corp, EV3, Codman, as well as direct MS Foundation funds and smaller donors whose generosity is greatly appreciated for us to really be able to do it. And finally, nobody got paid, as far as any of the physicians here or any of our members, for conducting this research. So we all donated our time and expertise to be able to do this. And this is still currently ongoing work. The only charges were associated with the actual hospital expenses incurred in conducting the trial.